Good afternoon. Those that have been kind enough to join our session, I appreciate it. I'm going to try to be brief. I know we only have about a half an hour time to cover this topic. My name is Hugh Morgan, and it's me on the left, and Vice President of Quality for Somnia Anesthesia. We're a national practice management company, and I'll be joined today by my colleague, Dr. Schares, who's one of our chief anesthesiologists at one of our medical centers. So again, going to try not to keep it too long today. So the focus really for today's session are these objectives, really, to really talk about the anesthesia financial risk, and also consider options. Really, that's the main message I really want to kind of convey, is the options that are really available to everybody as you look at anesthesia financial risk and anesthesia finances in general. Also regulatory compliance and how that impacts revenue. And then finally, the key performance metrics that really drive anesthesia financials. So as we kind of think about how the rules of the game, the healthcare game, have really changed recently, you kind of look at basically going from volume to really the right kind of volume. And that's how payers are now kind of reimbursing services, including anesthesia services. So it's also about the right partnership in healthcare. And this is an extract from an article on ACOs that was in the HFMA magazine about a year and a half ago, where it talks about clearly having the right partners in healthcare today. That's really the key differential. So healthcare, again, is kind of like taking a look back into the future of sorts. And we look back over 10 years ago to the Institute of Medicine, when they came out basically with what they thought at the time were really the 6 key dimensions of healthcare that was really going to be the driving force for healthcare in the 21st century. And again, I'll let you read them, but do no harm, evidence-based care, patient-centered care, certainly care without undue or unnecessary delay, care without waste of resources, really key and critical to the audience here today. And then finally, access, that equitable and accessible care for all. So concepts that certainly haven't changed in the last 10 to 12 years. And really, this became, I think, the basis for health reform. And for those that may not be aware, the Institute for Healthcare Improvement's Triple Aim project under Dr. Donald Berwick, who was just recently left the post as the CMS administrator. And really, the key here are the three areas to the bottom left, where it talks about the population of health, the experience of care, or patient satisfaction, and the per capita cost for that care. And how this really applies, again, specifically to anesthesia, is the population health is really centered around clinical outcomes and really looking at events and outcomes to quantify quality of care. Certainly, experience of care is satisfaction, and then the per capita cost starts to really drill down to that anesthesia subsidy that I know everybody typically struggles with. So as we think about anesthesia, sometimes folks just want to kind of boil it down just to the operating room. But as you can see, they're really hospital-wide intensivists. They're covering so many of your key critical areas in the hospital that it's really important for folks to really explore the different options that are available to you. So with that, I'm going to turn it over to my colleague, Dr. Schares, who happens to be one of those hospital intensivists.
Thank you, Hugh. So as Hugh mentioned, I'm actually a clinician, and I'm one of those folks right there at the front line. And part of my job is to translate this into day-to-day, night-to-night reality. So what I was thinking was, part of the challenge before was there just was ineffective clinical leadership. And the groups would often not be aligned strategically with the hospital and its goals and objectives. There'd be a disconnect. Like driving a car with the wheels out of alignment. And on the ground, there was just lack of operational expertise just to understand how to schedule, how to maximize resources. And then financially also just problems with managing the financial revenue and AR, and lack of management expertise. So this is for the non-financial people. We can all understand this is not good. It's tilted. We have too many costs, too many revenues. too little revenues. And it's all being balanced on a subsidy and stipend. This is a very common scenario, and it's a solution, it's a problem that needs to be solved. One example, one single example would be just canceled surgeries. Now obviously as clinicians you all want to do the right thing for the patient. If it's the right thing to not do a procedure, the appropriate thing is to cancel, but they're costs. And this needs to be looked at, managed, and make sure it's the right thing and if possible minimized. This is one example of how a team that's just going beyond doing the case, putting them to sleep, waking them up, where there's more to do to our job, and to be a true strategic partner to the hospital. So my particular assignment was Desert Regional Medical Center in Palm Springs. They asked me to come here today because they thought I'd be most acclimatized to the local climate, since it's over 100 there also. We're a 387-bed hospital, and 2 years ago they asked, the administration finally made the step to put out an RFP and see what other solutions were out there. And the hospitals identified themselves these main issues. Same issues, really not new here. That the group was unaligned with the hospital. They were going in different places in different ways at different times. They couldn't really identify who was the leader in the anesthesia group to even try to have discussions about how to change things. They were concerned about how productive the OR was. They had no idea if the care was good. And they were paying a lot in a stipend. So they chose, of the many potential solution providers, Somnia, and we put in a new team care model and basically tried to address all these concerns with solutions. The goal was this, and coming in up front, this was the goal, to balance revenues and costs and to minimize the stipend necessary to do that. These are the components, very coarse-cut components of all these things, revenues and costs. So here it just lists some of the detailed components of what we put in. First, we kind of know anesthesia, and anesthesia is different. And we put in a program of really being accountable. That also meant being transparent, communicating about what our goals were going to be. We wanted to, part of this transparency then resulted in communicating what we were doing. Both areas that we had achieved success, and being very frank and honest and open about areas that we had fallen short of what we had hoped, making the administration aware that we were aware of that and looking at our revised plan. In terms of addressing quality, we turned to some very, very strong external resources, which is the Anesthesia Quality Research Institute, and surveying existing resources, surveying the patients, surveying the surgeons. Pretty much every patient, every surgeon being solicited for their impression. And this actually is a very powerful package to help the hospital understand what's actually going on down in the operating room. And our goal was to be the top rung for SCIP compliance. Now that is not to come all about quality, but this certainly is the first one, and more as Hugh will go into, will be linked to financial results. And we also wanted to, once we're in, to do such a job that they would want to retain us. So here are some details about what we did. We changed some of the staffing models. We put in pre-op clinic testing to avoid the cancellations. Identified strong leadership, and had the leadership communicate very robustly with administration. Worked on improving the OR schedule, and we put in a model so that the times when we felt that we were being challenged, we pointed out to the hospital they were having similar challenges, and they were staffing ORs and there were no cases. What we show here is somewhat of a busy slide, but what it does show is the impact of the OR not being used. The impact of the OR being staffed and not being used. And in our model, we're highly aligned with that because it's not simply, oh, you do a case, you get paid. We align our compensation and staffing to align with the hospital's issues. What we also did was we implemented the anesthesia care team. Anesthesia care team being non-physician providers in the form of Schares who work together with anesthesia in providing care. So at this point, we had to discuss the issue about the anesthesia subsidy. And these are the components that we saw as minimizing the costs and that we tried to address. And at this point, Hugh, I'm going to transfer over to you, if I may, when we talk about the financial impact, quality. All right.
Thanks, Dr. Schares. So again, just to continue and really emphasize the importance now, as we know, of tying quality to the finances. Really, it's going from this anecdotal kind of approach of quality to really quantifying it, and really focused around two key areas: the physician quality reporting system (PQRS) and value-based purchasing, which again has several anesthesia components to it. And really, this also affects, as I mentioned here, the hospital's reputation and growth in many different ways. Accreditation and Department of Health compliance, certainly. Publicly reported outcomes that are in health grades that are available to the public now to see how the hospital is reported. And then, of course, patient satisfaction and also surgeon satisfaction. So really, this is how I kind of think the times have changed for anesthesia, where you kind of had the old anecdotal approach to things, and now it's really become the new quantified approach. And that goes for healthcare, certainly in finance as well, where you can see the transition. And really, again, at the very bottom, I want to emphasize going from the old Institute of Medicine concept of do no harm to really actually providing quality care. So getting away from a kind of a negative to a more positive connotation and what that means financially. So again, as we think about PQRS, and this is mostly for the independent or the anesthesia groups that are at your facilities, really what we're looking at are three key measures in anesthesia: prophylactic antibiotics, normothermia, and then the prevention of central line bloodstream infections. And two of those three must be reported 80% of the time that they're eligible on claims in order for the anesthesia group to actually receive that incentive back from Medicare. But what's interesting at the bottom of the screen, as you can see, the most recent 2010 CMS annual report on PQRS participation actually showed that most anesthesia groups weren't even participating to get that free money. So in other words, it's kind of like just walking away from, I guess, the table out here in the casino when there's free money on the table. And of course, this directly impacts the subsidies that the hospitals are paying to the anesthesia group, right? So if the group has just walked away from free money, but they're going back to the hospital with their handout looking to compensate, then they're basically left that money on the table. And then as we think about how anesthesia impacts value-based purchasing for the facility, we're really talking about, again, similar measures with prophylactic antibiotics. Now we look at beta blockade during the peri-op period, and then postoperative glycemic control for cardiac surgery patients at those facilities that are doing cardiac surgery. And again, so as you think about all of the current value-based purchasing process of care measures, anesthesia comprises 25% of the measures that are impacting your bottom line through value-based purchasing. So not a small number, and I don't know if there's any other medical specialty that has that same impact on value-based purchasing like anesthesia. And then of course for the HCAPs, the patient experience piece, anesthesia probably plays most importantly to pain management, although clearly they do impact all of those other components there as well. So really for anesthesia, the value-based purchasing bar is pretty high. Essentially it's 100% is the benchmark for the process of care measures, and then the HCAPs, the pain management measure, is relatively low to achieve. But you know, the threshold, of course, at the where the bottom line is for the medium level for these measures as well. And then this slide is really showing kind of a projected impact for you folks. And this is again looking at a facility that is doing about $100 million in annual inpatient Medicare revenues, and looking at the total risk that's available kind of from fiscal year 2013 that we're about to enter in, all the way over to fiscal year 2017 over that 5-year period, and looking at what's going to be projected in the out years in the value-based purchasing program for the hospital-acquired conditions that will be added in the successive years to come. So clearly there's a significant amount over this time period that is at risk for your facility, and again, much of that is tied to anesthesia. When we also think of compliance risk and how that ties into anesthesia through the conditions of participation, you can see the new rules and regulations are really that anesthesia must oversee anesthesia throughout your entire hospital. So they really have to be involved and integrated, working with your hospital medical staff and really making sure that that integration is taking place, because it's now a CMS requirement. And certainly you can see some of the other requirements as well there from the Joint Commission. And what's interesting I want to point out is the last bullet point about this past January, where the Office of the Inspector General released a very alarming report that reflected about 86% of the time in our hospitals, adverse events are not being reported. And they were able to do that by circling back around using claims-based data and going back to those facilities to see if those events were actually reported. And I bring that up because, again, as we talk about quality and compliance and the key for anesthesia in all of these areas, these are some of the questions that you really have to kind of ask yourself about your current anesthesia practice or your services. Are they achieving those top skip compliance numbers so that you can maximize your value-based purchasing incentives? The PQRS measures, right? Are they maximizing and reporting those so that they can earn more revenue and not have to go to the hospital for more money there? Are they overseeing the delivery of anesthesia throughout the hospital? Have they implemented a comprehensive quality program so that it's supporting the quality program that exists at your facility? Are they conducting satisfaction surveys, both for patients and surgeon satisfaction? Are they doing compliance audits on a regular basis, just like at your facility, so that their staff are constantly on their toes and aware of the survey readiness criteria? And then have they validated those qualitative results with some national organizations such as the Anesthesia Quality Institute and their benchmarks? So in the end, just like I mentioned up front about having that right partner as we progress through the challenges that lie ahead, I would ask if you have the right anesthesia partner as you consider all of these different key components on the screen about effective leadership, alignment and integration with the hospital mission and goals, the transparency of the group and the key. Are they accountable to the costs of care, the financials of care? Are they quality focused? Are they patient centric? And is the subsidy accurate, right? That big number, that subsidy number, do we really know what comprises that number? And is it accurate? Is it off by $500,000 or $1 million? And what are all of the factors that really go into that? So these are all really the key sorts of questions that I think are really important for us to ask. So that concludes our brief session today. I appreciate those that attended. I know it was kind of quick, but certainly I'm around. Dr. Schares is around, and